certainly, I think we were talking about diagnostic tests specifically. The science around the serology test is fast evolving. We're interested in that too, as we've talked about, and Governor Walz has talked about, both to understand the spread of the disease in the community and potentially as a resource for helping assess the safety of return to work strategies, particularly possibly in healthcare. But I think the prioritization for people with the diagnostic testing or molecular testing is where we're focused right now.
Yep. So to reiterate, we have a list of priority individuals for testing, and many of our partners in healthcare have not been able to get all the way down the list. And so before we talk about expanding, we'd like to know that we have been able to successfully reach all the people on the current priority list.
Thank you both, appreciate it. Your next question is from Esme Murphy. Your line is now open.
All right. Thank you, Commissioner and Chris Ehrson, for taking my question. My question is, and I do have a brief follow-up. Today, there were protesters outside the governor's residence demanding a quick reopening of the state. There have also been political personnel that have been calling for a quick reopening of the state. From your position and as health experts, what would you say to those protesters who are urging the governor to quickly reopen the state?
Well, I think this is Jan. I would just reiterate what the governor has said, that decision needs to be carefully considered based on where we are in the epidemic, how safe we think it is for people to return to moving around the community based on what we know about the degree of community spread that's going on. There's been a big priority on trying to develop guidance and criteria for workplaces that currently are functioning because they are essential parts of the essential workforce. And as we look to reopen other sectors of the economy, doing that in a way that can allow as much security as we can help those workplaces have in terms of their screening protocols for screening out ill workers, really adhering to those guidelines around ill workers going home, isolating, all of the things that we need to do to make sure that we're not seeing rapid spread in a workplace. That is something we work hard to avoid. So I think everybody understands the desire to return to work, to return to engaging in the community. As the governor has said, nobody's more eager for that than he is. But we've also seen, and he's mentioned the example of the Smithfield plant, that doing that prematurely or where we don't have the measures in place to assess the safety of a workplace can really backfire and put you in a worse situation than we are today.
Chris, do you have any?
In addition to what the commissioner said, I think we also have to remember that one of our goals was the preparation of our healthcare system, and that is ongoing as well. So not only do we want to make sure that we have the plans in place so that people can safely return to activities, but we want to know that we were able to use the time to shore up our healthcare system and make sure that that has happened.
My follow-up is just on mask etiquette. I'd like to ask both of you, are you regularly wearing masks when you're out in public? Are you recommending that your family members do it? And what advice do you have to the public in terms of wearing masks, when to absolutely try and wear them?
I'll just speak for myself. It's a great question, and I think it's important that we all think about this. Personally, I have suggested to my friends and family, and I am doing it myself when I go to the grocery store or the drugstore. I do wear a mask, and again, we've kind of talked about the reasons for that. Is for if I'm wearing a mask, I am trying to protect protect the people that I'm interacting with from the potential that I may be ill and not know it. And we have said over and over again, cannot reinforce enough. Just because you have a mask doesn't mean that it's fine to go out and circulate if you have symptoms, if you're ill from anything. So again, a mask is not permission to not adhere to the stay-at-home guidelines, especially if you're ill. But I think it's I'm protecting you if I'm wearing a mask, and you're protecting me if you're wearing a mask. So I do think when we're in especially in situations where we're probably in closer proximity to people being in stores or what have you, that it's a good idea.
Yep, and I'll second that. I was very grateful that I'm not very handy. I can't sew, and so someone provided me with our family with some masks, and so I'm grateful for that.
Thank you.
Your next question is from Matt Sepik. Your line is now open.
Hi, Commissioner and Chris. Are you confident that the PCR serology tests that you announced today, they plan to scale these up to 10,000 a day? Are you confident that these tests will work and do what the researchers say that they will do?
Yeah, again, I just have to defer that I am not an expert on the process of validating the tests. I think certainly the university is a very credible organization. I don't know if Chris is more familiar with their specific the specific tests they've developed, but I think we've emphasized before how important it's going to be that with all kinds of tests coming onto the market, that Minnesotans be assured that they are reliable. So again, I apologize. I have not seen that proposal in any detail. I don't know if Chris has.
I have not, but I just wanted to clarify something because you said PCR serology, and those are two different tests. So there's a molecular test, which is the PCR test, which is used to test for current infection, and those are the tests. That's the test that's currently being done, and those positives are the ones that are getting reported to the health department. Then the serology test is a different type of test, and that's a test that would give us information about whether an individual has been exposed to COVID-19 and developed antibodies. And so they're kind of two separate things. So just to be clear, we can't comment on the specifics of what the university proposed, but just that those are two different kinds of tests that they're talking about with two different purposes.
Right. Yeah, I kind of combined them together in my question because they say they will give everyone both of these tests to determine two different things. What's your understanding then of how quickly we can expect these 10,000 tests a day once the U gets its funding? Say the legislature approves that today or tomorrow. What's your understanding of how quickly that process could be ramped up?
Yeah, again, I apologize that I don't know more about the details here, but I'm not sure whether the U is proposing to do that testing for other health systems or whether those would all be tests that would be administered through the university system somehow. So that, and we've talked before about the fact that the supply chain issues, come into this from multiple different directions. So it's not just the laboratory that has capacity to run the test, but it's also, do we have the capacity out at the points in the community where the samples are being collected to do that from the swabs that we've been talking about and the transport medium that it takes to get the samples to the lab. So again, I apologize. I don't know if what the U is proposing is just on the laboratory end or whether they're also proposing to do the front end of the process.
Okay, thanks, Commissioner.
Your next question is from Tim Nelson. Your line is now open.
Hi, thanks for taking my question.
there's been sort of a steady drumbeat in the last 72 hours or so, including the article in Nature Medicine yesterday that suggested as many as 44% of these cases, or 4 in 10, are transmitted before symptoms appear. And I know that, you know, the people that are sick have been your emphasis for testing. Is there some point at which the asymptomatic spread is going to change your testing criteria and you're going to go after these, you know, invisible spreaders more aggressively?
I'm going to ask Chris to respond to that. I think it gets to the point that there's multiple purposes for our testing strategy, or multiple goals that we need to achieve. And the first and the priority so far has been, as you said, assessing the status of people with symptoms, especially those for whom that might matter to their course of treatment. But given what we're learning about asymptomatic spread, certainly that's part of why we've talked about our syndromic surveillance system, but expanded testing of the right type under the right circumstances could be helpful to understand the spread from asymptomatic folks as well. But I would defer to Chris for a more precise answer than that.
Well, I just want to comment on a couple of things. One is, while we're not testing asymptomatic individuals at this point, we do recognize the potential. And so our contact investigation, our looking back on an individual's activities, does go 48 hours at this point prior to when their onset of symptoms started. So we have adapted, as we've learned more about COVID-19, we have adapted our practices to account for that. So we're currently looking at potential exposures prior to disease onset. And certainly, yes, there's been a lot of talk about asymptomatic spread. And I think that as we move further along in this pandemic and as our testing capacity increases, those will all be goals that we have. But right now, we aren't even able to test all the folks that are symptomatic. And so our goal is to, take the information that the positive that the universities provided and Mayo, and work with the health system to figure out how do we work together to make testing more available. And we're starting with symptomatic individuals at this point, but we're aware of the issue of asymptomatic transmission. And as I said, we've adapted our practices as that new information has become available.
Thank you.
Your next question is from Erin Hazanzadeh. Your line is now open.
Hi, thanks. I'm going to build a little bit off of Esme's question. I think with the protesters today, with so many mixed signals, I think a lot of people are wondering how close are we? Are we closer to reopening in some capacity than not? And the mixed signals I'm talking about are, Wisconsin extending their stay-at-home order, saying we're not going back to school till the fall. New York has so many cases. Other states have so many cases. At the same time, we don't. And I think we're getting this sense that some Minnesotans just don't know where we're at. So from a medical perspective, can you say if we're closer to one side than the other in all of this?
Well, certainly we are happy about the fact that we've got lower numbers of cases in Minnesota and lower numbers of deaths, though everyone is a sadness for family and friends. So we know that we're in a slightly different situation than some of our neighbors. What we have always been careful to say, though, is we don't know what might happen next. I mean, we're keeping a close eye on whether the growth rate is picking up. We're keeping a very close eye on the settings that we know are of particular risk. We want to work harder to understand if there's anything we can do to identify emerging hotspots, clusters of cases in a community, and jump on those as fast as we can. So we just keep saying we don't want to assume that just because we've got a pretty measured pace of growth right now that's going to continue. So and certainly the governor is going to be looking at a whole range of data points and factors as we get closer to May 4th. I think he has said that he's eager to work with the business community and to understand, as we already talked about a little bit earlier, are there environments where it is safer to be circulating? And with the return of good weather, what's our guidance for people being outside? Is going outside a good thing? We still want to avoid large group gatherings or close proximity in the outdoors, but we think that there are, to the extent we can not just totally ignore the fact that there's a lot of community spread and a lot of risk out there, are there ways to protect ourselves and protect each other that allow us to gradually increase what activities make sense? It sounds like an evasive answer, I realize, but it's just there are so many variables to be considered. And it is, it is difficult, I'm sure, for folks to understand why are different states taking such different postures with respect to some of these things. And it's been helpful, frankly, the last couple of weeks with a little bit more federal consistency about the importance of staying at home as much as possible. I don't know what the president's going to be saying later today about that, but we'll see what additional guidance might be forthcoming or suggestions might be forthcoming from the CDC and others.
And then just to follow up, I mean, we discussed the other day the possibility of restaurants doing temperature checks and spacing out tables or having people eating outside. Does that feel like that's weeks away, or could that still be months away?
It's just hard to speculate. And I'm sure people are looking for more certainty than we can give today. But it's that next decision point is a couple weeks away, and as the governor has said many a time, things can change pretty quickly. It's hard for us to know what is our what's the situation going to be like, a week from now, much less 2 weeks from now, in terms of what's happening to our growth rate of cases, what's happening to healthcare capacity, what's happening with, increased information about the virus itself. Some of these things that we're talking about now around asymptomatic spread, for example, are quite new. And we're learning new things every day. And I'll just see if Chris has anything she'd like to add.
No, I mean, I'm with everyone who wants this to be over, because I can assure you the commissioner and I feel exactly the same way. But there are just a lot of factors to consider, and so it's really difficult to be several weeks out and know that there'll be more data coming in the next weeks that would help inform a decision. And so it just seems wise to let that data come in and to evaluate it as we get closer to the time. Thank you.
Your next question is from Ricardo Lopez. Your line is now open.
Hi, yes. I just wanted to get a sense sort of around testing. I saw that in Iowa, a few other packing plants there have had workers and employees test positive, and so they're suspending operations. So I'm curious if you could walk me through what that situation might look like here in Minnesota, given the testing priorities and testing shortages. Like, how quickly, one, could you test, an entire workforce at a plant here, or, and then also how quickly you get positive results back once people are tested, typically in rural parts of the state?
Yeah, I think I'm going to ask Chris to take that one. The speed with which test results can be turned around, as we've talked about before, really depends a lot on which labs the healthcare system locally is using, and they have reported some fairly lengthy delays from some of the national labs that they've been using. But we've been really working hard to have pretty much 24-hour turnaround at the public health lab, and as Mayo and the other systems, and now the university, and the appeal of that, of using capacity closer to home, is certainly related to the speed with which we can get the testing done and get the results. And I'll ask Chris to comment on the speed with which we could kind of do the investigation.
Sure. So, we have worked to pre-deploy swabs, if you will. So we've acknowledged that swabs are a limiting factor for testing. So we've worked to get some of those in our district offices across the state where our field epidemiologists are. And so if there's a situation in which we would identify, there'd be a case identified in a workplace in which, like a meat packing facility or something like that, meat processing, we would be working with that workplace to identify potential exposures and to look at doing additional testing. And so we would work to make sure that testing capacity could be available, and then get those swabs back to be tested in an expedited manner. So if there was a situation like that, we do have some steps that we can take to respond. And I want to be clear, we're not testing every workplace, we're not testing every situation, but if there was a situation where we had perhaps multiple cases or cases with many exposures in a work site, then we could work to do some expedited testing.
Yeah, and as a follow-up, because I think you had mentioned this before, maybe, I hope I'm not misinterpreting it, but I think you said before that in certain laws, sort of congregate care settings, that if you had one lab confirmed positive, you were sort of presuming that everybody else probably had the virus as well. Would that sort of apply in a case of dense workforces like in packing plants like that? If you had one lab confirmed positive case in a workplace like that, would you assume that potentially it's more widespread?
Just to clarify, we are doing much more testing in congregate care settings. So what we do is, if there's a single case in a resident, employee, or contract worker, we take immediate action, and then we do additional testing in the setting. And so we would do that in a workplace situation as well, if that was warranted.
Okay, thank you.
Yeah, I don't think we meant to suggest, if we did earlier, that we would assume everyone in the setting has been exposed, but certainly working really quickly to make sure that folks are isolating and minimizing interactions. It was just a priority to try to further prevent the spread, and the enhanced infection control processes that we've talked about so often are so very critical in those environments. And the same would be true in workplaces, that part of increasing the safety of workplaces will be not only health screenings and testing and continued really rigorous enforcement of the isolation and quarantine guidance, but also enhanced cleaning practices as well, which is what's been going on in those long-term care facilities.
Okay, thank you.
Your next question is from Dave Orich. Your line is now open.
Thank you. I think for a couple of days now, some of us have been hearing the same question. It's not quite getting answered. Once we get enough tests, enough molecular tests, that we can get through the list of those prioritized, then who gets it next? What are the priorities after that point? In other words, when we're ready to start opening up, when the governor's standard has been met, who's going to get tested first? What's the priority list?
We will be working with partners in healthcare to have more conversations about that. But I would say that we're a ways away from that because I think, as you recall, our testing priorities include, long-term care, congregate care, congregate living, both residents and staff and guests, hospitalized, healthcare, includes individuals 65 and older. We have not been testing everyone who's symptomatic 65 and older. It includes child care and first responders. So, I mean, we have a long way to go. And so I think, we will see where we're at in meeting the needs of those groups, and then we will discuss expanded testing. But to the earlier question about asymptomatic transmission, we will move to another level of symptomatic testing, I think, first, before we would start considering asymptomatic testing when we have, a finite resource.
Okay, I'm still not hearing an answer. I totally get you, Chris. Those priority lists, they're going to get the test first. And so maybe that's not 5,000 a day, maybe that's 10,000 a day, or maybe it's 5,000 a day for some period of time. But we're just trying to envision who might go back to work first, who might have a sense of their own health. So once that list is exhausted or satisfied, who's next?
Can I just clarify something though? I mean, we're talking about the limited availability of the molecular or the PCR test, which tests if someone is infected. So we're not talking about serology, which would suggest that they've been exposed, they've had infection, that type of thing. So I'm confused about testing as a means to have someone go back to work.
Okay, sure, I'm sorry. The governor yesterday, as you listed off those same priorities, he began talking about how he wants to see everyone in Hormel tested. Those are people who are already at work. He's putting this that this molecular testing is part of our return to normalcy. And so I'm just trying to figure out who stands where in the hierarchy of that, I guess.
Thanks. Appreciate you. I appreciate the opportunity to clarify the question, because I think we're probably confusing each other here a little bit. I think molecular testing is important to keep on being able to identify ill people and to get them isolated and quarantined. But from a return to work standpoint, I think the governor was talking about serological testing, not PCR testing, as screening people. Certainly we want to continue to do enhanced health screening of workers coming to work to make sure they don't come to work if they're ill. And I think we do, whether they're, I don't have any insight into whether there are or ever could be tests that are so rapid that you could identify whether someone is ill literally on the spot. If that might have been part of the thought, but I think the governor was more focused on basic health screening to screen out people who are ill, and then trying to understand from a serological standpoint who's already been exposed and therefore would be presumed to be safer to return to work. But with all the caveats that the governor's also mentioned and that Chris has mentioned a lot about what we don't know yet about the power of serologic testing to really predict that. And that's where I think that both the university and I presume Mayo as well, there's a large research component to the serology testing that they want to do to better pin down where is it effective and where, frankly, is it not.
So I'm very glad you were able to clarify that, because I do think that's clearly been a point of confusion. I think the commissioner stated it well.
Okay, thank you.
Your next question is from Dan Svensson. Your line is now open.
Thank you, Jan. Thank you, Chris. One thing that's been intriguing from me from the get-go on this end of things is the number of people that have been tested, and you look at the the overall test compared to the positive results, it's been a pretty low percentage. Using today's numbers, only 4.6% of those tested, and those are the symptomatic people, have come back with a positive test. Can you pinpoint any reason for that within your, albeit lower than you want to, testing sample size?
I think I'll ask Chris to be more specific about this, but I think we've been saying for the last few days that the percentage of positive tests that we're doing at the state lab is much, much higher because we're focusing on those high-risk populations, the long-term care and other congregate settings. So averaging out all the testing across the whole state, I don't doubt your math, but when we're focusing on those higher risk populations, we do see a higher percentage. But Chris might have a broader picture there.
No, that's very true. That we're, the public health laboratory here is getting specimens from congregate care and congregate living situations, and we are seeing a much higher positivity. Some days a third of the specimens that come in are positive here. But we have to recognize that those are situations in which it's, we're seeing transmission and we're expecting to see transmission. We know that COVID is circulating in our communities, but there are also many other illnesses that cause similar symptoms. I think we've acknowledged that, the symptoms for COVID are similar to so many other respiratory illnesses that we deal with on a regular basis. If your hair turned purple or your ears turned orange, it would be so much easier to, know who to test and what you might expect from the test results. So I think that the goal to make testing more widely available for high-risk groups and symptomatic individuals is a good one, but not every illness and not every thing that is circulating is COVID, although it's a significant part of what we're dealing with.
I'd just like to just take the opportunity to say we have some confidence in our low case counts. When we even though we're not testing large volumes, we think we've been testing strategically. The fact that we've got a strong surveillance system, that we believe that we're on top of the great majority of hospitalized cases that are COVID positive, The fact that, Chris's team does such an extraordinary job of case investigations and contact tracing, the fact that we put social distancing measures, community mitigation in place pretty early on. We really do believe that those combination of things and the fact that people are really doing the social distancing, it really has the Minnesota community, as the governor has said over and over, is taking this seriously, and everybody's doing their part. We really do believe that we can point to some success in having managed this, pretty well, at least thus far. But again, we just never want to presume that that things are going to stay the same way they've been. That we're working hard to try to keep the epidemic, kind of at this manageable level. But we know we're not in control of everything.
And you just piggyback on what you just said there as a follow-up. You mentioned up to a third of those getting tested in congregate care facilities are testing positive. Is that a sign that the tests from the general public are getting more and more of a good signs that you just alluded to there, Jan? Or do you have enough general public information to really draw any definitive conclusions yet?
Oh, yeah. You mean we're getting lots of positives in the settings where we know there's transmission, and are we getting enough from the public to say, oh, we're in a good place now? I think that we can talk about some of the other things that we're seeing. We know that there's not the ability to test just everybody, as we've talked about. I can tell you that our influenza activity is gone. So social distancing has really eliminated transmission of that respiratory illness. So I think that our social distancing has had a great impact on respiratory disease. But when you're in a closed setting like a long-term care facility where everyone is together, your household ends up being, dozens of people instead of 2 or 4 or whatever. Then you're likely to see more transmission.
Operator, we have time for one more question.
Okay, your next question is from Carla Holt. Your line is now open.
Thanks so much, and thank you again, Commissioner and Chris. I just wanted to ask regarding the Midwest Coalition that the governor has announced today. The fact that it does not include some of our neighboring states, the Dakotas, Iowa, what does that say about its effectiveness, given that the whole point of the coalition is to, as a region, try to streamline our activities and make them somewhat consistent across the borders? And on that point too, if in fact the president announces an opening up of the overall country's economy, what will that do to any sort of regional effort if it actually has a counter effort, if you will?
Well, the announcement of some of the Midwest governors just a little bit ago, I think just underscores the fact that we know that this virus doesn't respect geopolitical borders very well. In terms of the Dakotas and Iowa, I know that Governor Walz and Chief of Staff Schmitter literally speak multiple times a week with their peers, and I have no insight as to why those states were or were not in the partnership. But I do know that the governor has said just this morning that he is and will remain in frequent contact with the governors of the Dakotas and Iowa as well. In terms of the national messaging, as we've talked about, it is challenging to try to mount a state strategy without kind of taking into account the interrelationship of our economies and the freedom of our society, which is so important. So I think the more we can have cohesive action, the better. But fully understand that different regions are going to be in different stages of the pandemic. So I will eagerly await what additional guidance and tools the federal government may suggest that we look at as we're considering those things at a state and regional level.
Okay, great. Thank you. I think that's the only question I have.
Thank you, everybody. I think that concludes today's call. If you had a question.
That was today's COVID-19 briefing by state leaders. As you might have noticed, Governor Walz was not on the call today.